So I work in the intensive care unit at Harvard in Boston, and I'm also an anesthesiologist. I have an interest in ethics with a master's in ethics, and I'm on the ethics committee at work. So today my talk is on something which are three different concepts in themselves, but I will try and focus on the intersectionality of these concepts. I do have a background in work in compassion, and I've been funded for this work, and through Harvard, we've published our papers on compassion, so trying to look at it from a 360-degree view. Conflicts of interest. I guess that's my conflict of interest. I'll start my talk with a saying from the Dalai Lama. Even a small act of compassion grants meaning and purpose to our lives. So very similar to what Joss was talking about, empathy, but here compassion is something a little more personal. I've always been riveted by this painting, and one of the inspirations for me to do a master's in ethics in my mid-career was this painting which is hanging at the Tate. I don't know if anybody's here from London other than Victoria, but this painting is called The Doctor by Sir Luke Fildes, painted in 1897. And here you see something which speaks louder than words, and this is really what compassion to me is personified by this physician who's sitting at the bedside of a child dying from typhoid fever in those days. And you can see how immersed he is in that experience. He's there, he's present, he's not typing on a computer far away, he's not ordering things somewhere. He's perplexed and devastated by the impending demise of this child, as much as the parents in the background that you can see are distraught, but yet they are not at the patient's side, at the baby's side, because they give that much respect to that physician. So the word compassion is ubiquitous in modern healthcare, yet few writers agree on what the term means, what makes it an essential trait. Although many modern writers have assumed that compassion is a universal and unchanging trait, the term is extremely new to healthcare. So when I did my literature review, I found that it hasn't been really used in literature before 2009. And the concept could have previously existed under another name, or empathy, etc., or sympathy, but it wasn't. Compassion itself was a concept which is fairly new to healthcare. There are many meanings of compassion to each one of us. Compassion could mean different things. Empathy could be one of them. But actually, it's a concept which incorporates a lot of things and not just empathy. But it has been defined recently by somebody who I've worked with. She's a director of the Compassionate Care Center at Mass General in Harvard. And her name is Beth Lown. She's one of my collaborators. And she has defined compassionate care of patients in the ICU. Compassion is defined as the recognition, understanding, and emotional resonance with another's concerns, distress, pain, or suffering, coupled with relational action to ameliorate these states. It has 5 components: recognizing the suffering, understanding the human experience, emotionally connecting with the other's suffering, being able to tolerate uncomfortable emotions. And this is where the fine line between too much empathy and empathy which is required and essential, and really the right of every patient that comes under our care to have us share that empathy with them and our compassion with them, and being motivated to alleviate their suffering. I'll move on to another concept that I'm going to talk about, and there is a fine intersectionality: spirituality. A lot of us who kind of reach their mid-career sometimes find ourselves, especially if we work in the ICU space, we find ourselves somewhat reflecting and introspective about our own purpose, why we do something, and why we work in the way we work. It is certainly not something that is what a young college student would aspire to at that time, that this is the kind of life I want, but yet we are in it and we live it, and we live it to the best of our abilities. And we find some solace from this concept, which is finding meaning and purpose in the things we value, the search for inner freedom, well-being, and peace of mind, an experience of living, flourishing, and finding hope amidst pain and suffering and difficulties, loving relationships with self, others, and something beyond, giving a sense of belonging, and being present in the moment. So these are the things that, especially during COVID, became very important to many of us, to give us that inner ikigai, which is a Japanese concept, which again talks about the inner purpose of what we do and why we do it. This is a picture, a photograph that depicts what our life is now, as opposed to the painting painted in 1887. So here is what we actually have been reduced to with electronic health records, with the kind of work that we do, the structural incompetencies of the work that we do, which kind of takes us away from the bedside, takes us away from really feeling that human connection or finding time for human connection. So just ponder on that for a bit. This is the picture and the book by one of my mentors who I value very dearly, also Dr. Hartog's mentor at some stage, Dr. Arthur Kleinman. He's a professor of anthropology at Harvard, professor emeritus right now, and he has really driven a lot of work around the soul of care, which means that he talks about in his book, and I urge you to read this book because I read it and it really changed the way I think about my patients. The contemporary crisis of caring globally is implicating the soul, implying medicine and healthcare has become soulless. They fail to engage the most deeply human experiences that require care, not management. We need soul to specify the human quality at the heart of care in order to animate the souls of patients, family members, and clinicians. So really the book talks about how our soul is within us taking care of our patients. So it's not just a profession, it's a calling, and it's very purposeful and very noble. So in the present day, here we are post-pandemic, where we have really somewhat lost the art of healing. And again, a lot of literature out there on this topic. Some of the sources that are cited in literature for the moral and ethical issues, dilemma, tension going on: non-beneficial life-prolonging care, family and ICU teams, disagreement, lack of patient autonomy, disagreement between surgeons and ICU teams, disagreement within ICU teams themselves, differences of opinion regarding prognostication, structural incompetencies that I mentioned, and lack of purpose. I want to talk about the third concept and the intersectionality. So I'll take you down history lane a little bit. Influences of religion and spirituality in medicine is really making a comeback since the JAMA article recently on spirituality and the role of spirituality, not religion, but spirituality in our healthcare in the ICU currently. Religion and spirituality will continue to influence healthcare on both patient and community levels, and it's up to the medical community to appreciate this. And this really is because medicine started from the intersection of religion and morality. And now we have come back to this because our patients demand that as a coping mechanism. So if you look at the history of medicine, it's one of the oldest branches of health science. Medicine refers both to an area of knowledge and to the applied practice of that knowledge. Doctor means teacher in Latin. Profession means to profess or to state. And ism is an ideology, as we all know. So whether it's the Messiah, Jesus Christ, or whether it's various forms of medicine practiced in history, so Ayurvedic medicine in Hinduism, Islamic medicine practice a long time ago, Romans, and then the Chinese, traditional Chinese medicine, it's been part of history. So religion, spirituality, morality, and medicine have been very closely linked. And it wasn't called medicine at that time. It was called caring and just being a very learned person who's able to take care of the human being, the soul of the human being, as well as the body of the human being. So I will thus present in this talk a historical approach, as well as several influences, and I will end on how compassion is pivotal for the future of medicine and healthcare, and why my research stands in it. So religion has complemented medicine in similar ways in many cultures and in nearly every age. Compassion and humanity are the basis of this intersection, And even today, many people view medical concepts and treatments from a religious perspective. It is very important. I know that as a trainee, I trained at Columbia in New York, a lot of intersection of various religions, very devout religious communities in that area in New York. And I was always taught, and this was during 9/11, I was always taught that do not bring religion in your professional work. Do not mention your religion. Keep your personality and your background out of it. And also, don't talk about the religion of your patients because it's unprofessional. And that was my training, first as a surgery resident, then as an anesthesiology resident, then as an intensive care fellow, and then as a young attending. And then I traveled and worked in Asia for 10 years, and I found how important that personal identity is to patients. I worked in Singapore for 10 years, and then back in Boston, and I find that that part of their identity is so important. It makes up who we are, whether you have a religion or not, whether you have a spiritual presence or understanding or not. But that personality is very important in understanding and forming a human connection with our patients. Again, the history is Ayurvedic tradition, 800 BC, and they talked about to feel human suffering, you actively engage in your own sensitivities, nervous system, and emotions in mimicking the feelings of one who is suffering. So exactly what compassion is about. Avicenna, or Ibn Sina, was the father of medicine in 980 AD, talked about purity of body and mind through compassion and justice. The Greeks and Romans in 750 BC, Homer and Hippocrates, talked about the concept of divine retribution and the need for morality and empathy as a mean for purification. And then traditional Chinese medicine in 206 BC, spirit is responsible for benevolence, awareness of suffering, empathy, compassion, and tolerance, and serves as a reservoir for ideas that bring meaning into life. And this really talked about forgiveness. But doctors were not always very moral. This is Agrippina, and actually she hired a healer or a physician to kill her husband, poison her husband, because physicians in those days were really in charge of the chemicals, and they were the ones with the knowledge about chemicals, and that's that was part of their job, is to hold the power, and medicine was not always as noble as it is now, until this gentleman came along, Hippocrates, of course, and he brought in the moral dimension to healthcare or to medicine, or what we call medicine now. And it's an ancient Greek physician, commonly regarded as father of medicine. But in those days, the Hippocratics were very, very small in number. They were not the majority of Rome. And then they started talking about morality. And then when the wars came, there was Christianity. And the physicians started becoming the ones that did good in the world, in the wars and healing and taking care of patients during the plague, etc. And then it went on to the point of moral rather than bodily reasons for sickness. So there was morality associated with how sick a patient was, or the outcomes were based on the morality of the patient. Most physicians were trained in ancient languages, moral philosophy, and social prestige. So physicians learned a lot about humanities, and that's where my research is now, more about the humanities which make us people and human beings, not just providers or physicians and nurses, but also the patients. And then also in the history of nursing, you look at the first nurses were actually nuns that were sent by St. Paul to Rome, and then Florence Nightingale, of course, that all about morality and doing the right thing and the ethical thing. So compassion embodies an ideal of character that is grounded in human dignity or respect for persons. This was the moral basis of many religious philosophies, as well as grounds for work of German philosopher Immanuel Kant. And then again, I don't want to go on too much about this, but Kant really talked about the categorical imperative, which links deontological morality with unselfishness and compassion. So here we're doing the journey from history and ancient medicine down to ethics in the modern era, and our capacity to reach out beyond ourselves into the lives of others allows us to work together for a common good and forms the basis for human success. And Kant said it is the moral imperative to reduce the suffering of others and not cause them harm, which is really the basis of our Hippocratic oath as well. Compassion, simply led by emotion. So this is where that question that the lady had asked earlier, that, the flip side of empathy, that if you are empathetic with a lot of sympathy and emotions, but you are, you are very visceral and prone to fatigue or burnout. But when compassion is combined with morality, that this is our purpose and we are doing this for the right reasons, and we are doing this to, even if somebody's dying, we are there with the patient, with the family, holding their hand. We are doing the right thing. It gives you some sort of satisfaction. When I have patients on ECMO and they're not a bridge to anything and they may be dying, it's very morally distressing, and when you see hundreds and hundreds of such patients, it can lead you to either kill yourself or burn out or just become a very nasty person. But the way that I deal with it personally, and a lot of my trainees ask me, is because I think of this in a spiritual way, that I am adding something to this journey that the patient is going through, and that journey that I'm walking the few steps with that patient gives something back to me as well. So it builds my strength as well. And therefore you can come back and continue your own journey. And this transcends just emotions around empathy and sympathy and compassion. Yes, I've cried many times, many reasons, many patient interactions. There's nothing wrong with that. But also deriving the strength from that interaction is very important. For that, you need your own personal spirituality. This is a paper I wrote with Dr. Hartog. It's on looking at compassion, where we used some video vignettes and showed it to physicians who are intensivists from around the world. And one thing that they all mentioned was they find it very, very disconcerting that they cannot sit with someone in the ashes like Job did in their spirituality. So they went back to their own spirituality, and they thought that the thing that worries them the most is that when they cannot sit in the ashes with their patients for that relationship building, not taking the physician-centered approach, and not offering solutions or advice, but taking the other person's view and being at their side. This is an initiative started at Harvard on health and religion and spirituality. We have chaplains of all religions, all faiths at Harvard, and sometimes we even offer people without any spiritual or any religious background, but they are just there to provide a presence for the patients' families, to give them the support from faith, which doesn't have to be any denomination. And that really adds a lot to the experience of the patient or the loved ones. And this is actually looking at how may religion and spirituality in concert with public health and the practice of medicine alleviate illness and promote human well-being. We found remarkable results in our burnout rates amongst our physicians, even if they have no religion specified, even if they have no personal faith. They find a lot of, I call it, we have code lavenders, where we had a run of suicide patients who came in brain dead. This was especially after the pandemic, young patients who had committed suicide, and then they were on the ventilator waiting for organ procurement. There was a lot of moral distress, so we called a code lavender, where we have the chaplain come and we have sort of a debriefing session with the residents, with the nurses, etc., and we just sit around and share that experience, but in a spiritual way. So these things they add meaning to what we do, and it also takes the sharing of our spirituality to another level. Bringing religiosity in our care can have a negative aspect as well. In this study, they found that if somebody has a positive relationship with their religiosity, it can improve the outcomes. It evokes the best in individuals, reinforcing active problem-solving behavior, and a kind, supportive God is looking out for them, effect on religious adjustments, emotional health. However, if a patient or a physician has a negative relationship with their religiosity, it can have a negative outcome. And they view that what they might be doing is against their faith, and it might impact and cause a lot of moral distress. We see that in conscientious objection to certain kinds of procedures in the operating room, having some sort of conflict with your own faith could have a problem. You could have a problem. So it could be positive, but it could also be negative. So in conclusion, the religion and spirituality can have a positive and or a negative role. It varies, it changes with each interaction. Self and soul wellness can benefit from introspection and emotional regulation through spirituality. Exploring a patient and family's real spiritual or religious needs and conflicts can build trust at times, and coping can be enhanced through soulful introspection, praying, or spiritual presence for staff and patients. With that, I end my talk. Sorry if I went over time.